Evaluation is really important, and I think it's quite sobering to remember that most quality improvement initiatives are poorly researched and poorly evaluated and often not written up. And so we keep inventing things unnecessarily. It's also very sobering to remember that when people think about doing some health service change, looking at the literature about it is rarely the first thing that people will do.
So I think it's really important for us as providers to take stock to see where we're actually going. Have we achieved our KPIs? Have we achieved what we set out to do? Is our clinical outcomes as expected? So we'd be looking at things like how many patients did we discharge back to the GP with the care plan. Of those patients that were discharged back, how many then were re-referred? So it's just basically soundproofing our clinical judgments and whether the actual framework for this model is effective. And I think it's important for commissioners to then, when they're recommissioning the services, obviously from a quality point of view, they're interested in whether we've delivered on what we said we would deliver contractually, but also from a quality perspective.
At the Royal Free side, every year we go through patients who are unplanned starters on dialysis. And before we set up this virtual clinic, a lot of the unplanned starters were coming from the North Middlesex and had diabetes. And over the years, that number has declined. And in the past few years, we haven't had any who've been come through this route, which I think means that we are achieving something. We also look at our mortality, because mortality increases if you have an unplanned start. So by reducing the number of unplanned starters, their outcomes are better. So we look at our mortality, our morbidity, and our number of unplanned starters. But that's been a very well-established routine.
We were very keen to evaluate it on various grounds. So in terms of the patient-clinician dynamic, we wanted to make sure that it was suitable for the patients that we are trying to use it for, that we knew the conditions that we could use this for, the kind of things that we could discuss online, how wide it could be used in various patient groups, for example.
So we wanted to do an impact evaluation that addressed the changes in both primary and secondary care. And we spent quite a lot of time thinking about what are the key metrics. And that's really difficult. And of course, the crucial thing is, do you think those key metrics are going to change in response to your program? And can you actually get data on them? So those are two important questions you have to ask yourself. So in primary care, we decided we'd look at CKD coding and the management of CKD, things like blood pressure control and statin use. In secondary care, we were really interested in the effects, the impacts on the clinic. And so we were interested to know the actual numbers of virtual appointments, what the outcomes were, so how many translated into face-to-face appointments, what the follow-up rate was, and also, importantly, change in wait time for GPs.
I think it was quite an eye-opener because it has not achieved a few things we thought it would achieve. So we haven't managed to release huge amount of finances in the short term because it has involved a greater element of system redesign. And it's quite naive to imagine that just changing some appointments from face-to-face to online appointments on its own will achieve everything that we set out to achieve. And we came to realize you needed to redesign the whole outpatient pathway to make it achieve what we planned to. So it didn't relieve a lot of money. So where we had put in a lot of SIPs, for example, against virtual appointments, we didn't realize those in the short term. But it did help hugely as people kept using it in terms of things like non-attendance rate, better use of outpatient times. So, then we were able to do some economic modeling with our finance department to look at how we might actually release these savings if we were able to group the face-to-face appointments together, for example, into virtual-only clinics, because then that helps you release outpatient space, for example.